It is visible now, right? Yeah. Hi. Good evening to all, and thank you very much for the opportunity which has been given to me. And I'm thrilled to be sitting with Professor Atul Kumar, Dr. Shubhadra Jalali, and Dr. Desai. I'm their student, and I'm quite junior to them, but I'll still try and keep up the expectations. So. I would be discussing the role of ultra-wide field fundus fluorescent angiogram and ICG angiogram in clinical practice, in day-to-day practice. And actually, most of these points have been already been touched by Professor Atul Kumar and Dr. Jarali. I have no financial disclosures in this study, but I would still like to thank Dr. Srinivas Saradonia Institute, Los Angeles, and Dr. Yano Hemmert from Optos, UK. I would also like to thank the Optos Cornell Medical Instruments, Mr. Deepak and Mr. Amritansh for this opportunity. These points, actually, I'm going to skip a few initial slides because they have already been discussed now, that the documentation can be from 30 degrees to about 200 degrees in a single capture right now, and montage can increase the amount of capture. This initial management strategies were all laid in the DRS and ETDRS trials with the help of 7 field stereoscopic photographs. They were 30 degrees photographs. And as we can see here, they could encompass an area of about 75 degrees or 34% of the retina of the posterior pole to be able to detect the lesions. And based on these, the diabetic retinopathy severity as well as the lesion detection was planned. So as far as the standard definitions, I think Professor Atul has already spoken about them. The standard imaging is from 30 degrees to 50 degrees. When we talk about a single image, we don't talk about montage in this. And when montage, this can increase up to about 75 degrees. A wide field imaging goes beyond 50 degrees, and an ultra wide field imaging goes beyond 100 degrees. This composite picture I have actually taken from the American Journal of Ophthalmology. It tells us a fairly good idea about how much a standard 7-field ETDRS field encompass versus a wide field 100 degrees optos, and versus the whole background, which is the 200 degrees ultra wide field optos. Before the onset, before the development of the present day ultra wide field systems, researchers have tried to increase the field of view of the fundus with the help of contact lenses, coaxial illumination, and special mirrors. And they could achieve a field of view of about 150 degrees, but it was cumbersome and it has not been practiced so far. This was again the same study by Professor Atul Kumar. And all these systems have been used, and we can see that it's lasts about 4 decades that the ultra wide field systems have been developed. They can be contact as well as the non-contact systems, but we'll restrict ourselves to those which are important in terms of carrying out the FA and the ICG systems nowadays, the Optos, the Spectralis, and the Zeiss Claris 700. So before I go on to the clinical utility, I would like to touch upon the features which have made these systems much more user-friendly, both to the clinician as well as the researcher. So let's go to the optos. For example, these images are known as optomap, and a stereographically projected image in the optomap gives us the exact image size as well as the dimension. I'm going to touch upon this software in a little while, maybe about a couple of slides later, because this is very important for a clinician as well as a researcher. The registration software is kind of an overlay technique which we have been doing with the FF4, the 450 plus Zeiss camera, and it is helpful for the longitudinal studies as well as the lesion, what happens to the lesions over time. Area measurement is with the help of when the area has been marked by the graders and the white pixels can be assessed accurately with the help of present day softwares like ImageJ, GIMP, or Photoshop. And montaging, we have been using montaging for a large number of years so far. But as we can see here, with the help of optos, about 220 degrees, that is 97% of the retinal surface area can be very well seen. Unfortunately, this is not available for the ICGA images, but I think we can expect this soon. One more important feature is the we have the ability to overlay an ETDRS grid over the optomap image, and the researchers and the clinicians can find out whether the lesions lie within the standard 7 fields versus the lesions, whether the lesions are peripheral. And actually, one of the studies I'm going to quote upon we have done in the Indian eyes regarding the diabetic retinopathy on the Optomap images. Lesion detector detects the presence of microaneurysms and hemorrhages, and this is very important because now we know that hemorrhages and microaneurysms are the lesions which are the most important predictor for diabetic retinopathy severity as well as progression over time. The AVR and the caliber measurement can be done in a particular section of the retina, and in the caliber of the vessels in exact millimeters can be given by this. So this I wanted to touch upon briefly, the stereographic projection, which is incorporated in the optos nowadays. So what happens in the ultra wide field images is there is a significant non-linear wrap in the periphery. So a lesion in the center might be taken as a standard. The measurement might be accurate, but as the lesion goes in the periphery, the lesion appears to be larger than their actual size. And once the stereographic projection is applied, that means the curved eyeball is made straight. And with this, the lesion size, the area, and the correct distance from a specified landmark in a corrected dimensions can be obtained. And the measurements become really accurate. Similarly, Zeiss Claris comes with the options of montaging. It also comes with the options of a true color imaging in contrast to the Optos, which is a pseudo color imaging. And it comes with the options of composite imaging of the eyeball, all these techniques in a single module. Heidelberg comes with the options of multi-lens systems, the 30 degree, 55 degrees, and the ultra wide field 102 degree lens. It's a little bulky lens, but all these lenses can be incorporated on the machine in the same angiography setting. The simultaneous ICG and the fundus fluorescent angiogram also is an option with Heidelberg Spectralis. And now I'm going to come upon what are the clinical implications of the fundus fluorescent angiogram and the ICG angiogram in day-to-day practice. The only question which comes to my mind, is it really necessary in day-to-day practice? Because we have seen plenty of the examples in the last two presentations. The peripheral lesions would be missed, and definitely our treatment strategies will change. I'm going to touch upon this now. Let's start with the fundus fluorescent angiogram. The first disease which I'm going to talk about is diabetic retinopathy, because I believe personally that the ultra wide field imaging has changed our understanding about the diabetic retinopathy, because what we are seeing is much more than we used to see before. Even the studies indicate that about 40% eyes with DR, the retinopathy occurs in areas peripheral to the standard 7 fields, and which implies a more severe level of DR in about 9 to 15% of eyes, and this is a significant number. We actually wouldn't want to miss this. The ultra wide field imaging also has been able to detect about 50% more of hemorrhages and or microaneurysms, and these are extremely important in predicting the lesion progression, the progression of the diabetic retinopathy. It has also been seen, PPL here stands for predominantly peripheral lesions. It's also been seen that the eyes with peripheral lesions had about 3.2-fold increased risk of two-step progression or more of diabetic retinopathy, and about 4.7-fold increased risk of progression to proliferative diabetic retinopathy. And as the number of fields with peripheral lesions increased, the risk for progression of diabetic retinopathy increased. So actually, we recently published a paper. We conducted a study with 4 centers all across India. We got the images from the Optos Daytona, and there were about 1,467, if I'm not wrong, eyes. And after the stereographic projection and the overlay of ETDRS grid, what we found out, we analyzed the lesions which are in the central fields versus their corresponding peripheral fields. There were 5 in number, because the central 2 fields will be incorporated into the whole boundary. And what we found, that about 1/3 of the eyes had a predominantly peripheral lesions versus 2/3 which had the central lesions. So these 1/3 eyes could have been missed if the ultra wide field imaging is not done. As far as the peripheral distribution is concerned, over the grades of diabetic retinopathy, more or less the uniform pattern was seen. We also saw that the number of fields with a peripheral distribution for any given level of severity of diabetic retinopathy was 46% of the eyes had one field with a peripheral distribution. I'd like to take your attention to the last two, that the 7% of eyes had 4 fields where the lesions were peripheral, and 3.5% of the eyes had lesions which were peripheral. Combined into the quadrants, we also showed that the temporal field showed the greatest peripheral lesion frequency and the nasal the least. So a very good publication by Vessel et al., where the fundus fluorescein angiogram has been incorporated in the ultrawide field system. They showed that the ultrawide field imaging imparts about 3.2 times more total retinal surface area than the standard 7 fields. They also showed that 3.9 times more of the non-perfusion, 1.9 times more the neovascularization, and the need for pan-retinal photocoagulation was about 3.8 times more when the imaging was done with the ultrawide field technique. And in 10% of cases, the lesions, the pathologies would have been missed if the ultrawide field technique was not used. Now I'll just touch upon a small definition which has recently been introduced in the in the ultrawide field era. This is ischemic index. This is to quantify the amount of retinal non-perfusion. This is more of an indirect way of quantifying the non-perfusion. So what happens is we express this result as a number of pixels within the regions of non-perfusion as a percentage of the total visible retina. Now, once the stereographic projection has been introduced by optos, what happens is the same amount of non-perfusion can be actually calculated in the actual exact area in millimeter square, and becomes a little easier for the researchers to tell the amount of ischemia which in a particular fundus. So this study by Patel et al., they also showed that the ischemic index ranged from for the NPDR to PDR eyes from 0 to 65%. In addition, they also showed that more non-perfusion required more treatment with macular photocoagulation, and 80% of eyes with recalcitrant diabetic macular edema showed the evidence of untreated retinal non-perfusion. Professor Atul just recently mentioned this. And talking about the retinal vein occlusion, one important study which I'm going to quote here is from Nicholson et al. They showed that the risk of neovascularization was 0 in eyes with less than 10 disc areas of non-perfusion, which increased to about 80% when the non-perfusion area increased to about 75 to 150 disc areas. This is not very significant. The significant point is this, that if the 10 disc areas of more of non-perfusion was seen in the periphery, the risk of development of neovascularization was about 7.7%. But if the more than 10 disc areas of non-perfusion was seen in the posterior pole, the risk was about 85%. So what I'm pointing out here is it's important for us to do not miss out the posterior pole lesions when the ultrawide field is being done, and do not miss out the peripheral lesions when the central imaging is being done. So they also concluded that the posterior pole non-perfusion of more than 10 disc areas still remains a key risk factor for the development of new vessels in the eyes with vascular occlusions. A recently conducted study by Sunil Kwan et al., WAVE study, they divided the retina into the perimacular area, the near peripheral area, mid peripheral area, and the far peripheral area. And they suggested that the severity of macular edema correlates with the ischemic index of the entire retina and the perimacular area. And the reduction of macular edema was also correlated with the amount of ischemia of the entire retina, as well as the ischemia in the near periphery and premacular area. So again, importance that the posterior pole disease should not be missed. So based on this, recently a few clinicians have attempted a targeted laser in eyes where the PDR was not settling, and they showed that the regression of PDR was seen in about 76% eyes in 12 weeks, and complete regression was seen in 37% in 24 weeks when the laser was targeted or done to the areas where the ischemia was still seen. The same the results have been noted for RVO as well as in eyes with recurrent vitreous hemorrhage. I'm going to touch upon about the retinal vasculitis and the role of ultrawide field fundus fluorescein angiogram in these eyes. A study showed that about 60% of the eyes, the vascular pathology was identified only with the help of ultrawide field fundus fluorescein angiogram, and this is quite a significant number. In 20% of the patients who underwent the treatment solely on the basis of ultrawide field diagnosis. This study by Professor Atul recently was published in 2016, also showed that 1/3 of the eyes, the immediate treatment plan was changed because of the changes picked up on the ultrawide field angiography, which is a significant number when you're planning for a treatment for the eyes with vasculitis. Okay, a small and just a few slides about the ICGA angiogram. This was first attempted by Takahashi et al. In 1996, who was able to get about 70 degrees of the wide field, but recently in 2015, the first utility of the ultrawide field system in the ICGA angiogram has been published, which was done using Opto's P200TX system. This study by Klufas et al., they analyzed about 165 eyes with various diseases, and they published a host of findings with the help of ultraviolet field ICG angiography. For example, in AMD, they were able to show the extramacular early occult CNVM, which was also called as the vascularized pigment epithelial detachment. In CSR, they were able to show the prominent dilated choroidal vessels. In polypoidal choroidal vasculopathy, they were able to show the polyps which are seen in the periphery. And studies have shown that the choroidal vessels as well as the ampullae, the vortex veins get they are seen to be congested in the eyes with PCV, and they can be picked up only with the help of the ultraviolet field ICG angiogram. Even in the eyes with CSR, the dilated choroidal vessels and the congested vortex vein ampullae have been seen with the help of ultraviolet field system. In age-related macular degeneration, asymmetrical choroidal venous pattern in the eye with the AMD and in the fellow clinically normal eyes has also been noted. One paper which I got, which also suggests that in eyes with VKH, also they had the presence of diffuse leakage from the choroidal vessels, which was seen with the ultraviolet field system. Now, so far we have discussed about the diseased eyes. What happens unless until we know the normal, the diseased eyes cannot be analyzed. So I wanted to see exactly how many publications have been where the normal eyes have been evaluated. One study by Dr. Michael Singer, what they did was they analyzed the fundus fluorescent angiogram ultraviolet field technique of the peripheral retina in the normal healthy subjects. They montaged the images and the graders graded, and they were able to, they were able to mark the area where the vessels ended. And in the fundus fluorescent angiogram ultraviolet field system, the end of the vessels is still seen better as compared to ICG angiogram. The mean, what they showed as the mean radial surface distance from the center of the optic disc to the peripheral edge of the visible vasculature was 23 millimeters. This was after the stereographic projection. So I'm again stressing the fact that the lesions the dimensions are very accurate. They also showed that the mean area of normal perfused retina in a healthy eye was about 977 millimeters square. So what we did was we also tried and did a normative study in the normal healthy eyes using the ultraviolet field ICG angiogram, and we have recently published 2 papers here. This was conducted in association with the Medical Center of Ophthalmology Associates, Texas, USA, and the grading was done at the Dohenia Institute, where I was working about 2 years back. The instrument used was Optos, California. The aim of the study was to analyze the choroidal circulation using ultraviolet field ICG angiogram in normal healthy eyes. It had 2 arms. The arm 1, where we tried and analyzed the number and distribution of vortex veins, which are seen with the help of ICG angiogram in the healthy eyes. The arm 2, where we analyzed the mean area of peripheral choroidal circulation and its distance from the optic nerve in healthy eyes. Again, the fact that we stereographically projected the images and viewed with the help of Optos advanced software. The vortex vein ampullae were first marked in the predefined fashion, and once they were marked, the distance from the center of the optic nerve was calculated. And the results showed that we saw about the 8 vortex veins on an average, which ranged from about 5 to 13. And the mean distance of vortex vein ampullae from the optic nerve was about 14.2 millimeters. The frequency of ampullae were higher in the superior and inferior quadrants. And of note, the ampullae were never observed in the 3 and 9 o'clock meridia. Similarly, as far as the peripheral extent of choroidal circulation is concerned, we marked the peripheral boundary with the help of image J. And then because there is no montage available with the ICGA system, the Optos company, what they did was they created the rest of the boundary based on the boundary which we have already marked, and we were able to get the virtual map of the peripheral choroidal circulation. And we compared the result between the grader 1 and the grader 2. Grader 1 was myself. And the results were that the mean area of peripheral extent of choroidal circulation was 893.2 millimeters. Here, the importance is the fundus fluorescein angiogram, the vessels in the periphery will be seen very clearly as well, and when you compare it with the ICG angiogram, the vessels peripherally may not be seen very accurately. They blur out. The mean distance of the peripheral choroidal boundary from the optic nerve center was 18.2 millimeters, and there was no association with the age, the gender, the ethnicity, as well as the presence or absence of a smoking history. So I'd like to conclude my presentation by a small take-home message. Ultra-wide field imaging has increased our understanding of the retinochoroidal diseases, clinical course, as well as the outcomes of treatment. It should be used as an adjunct to the standard field imaging, implied in imaging of vascular as well as non-vascular pathologies, and enormous potential for research studies at present. Thank you very much.
Thank you, Dr.